Hi, I'm Melanie, and I'm going to show you how to perform a newborn assessment. So before we start the assessment, we're going to ask the parents' permission if we can assess the infant. We're going to wash our hands, and we're going to identify the baby through the parents before we look at the ID band as to not disturb the infant right now. We're going to make sure the vitals have been documented into the computer and that they are within normal limits. We're also going to gather our supplies, so all we need is an infant stethoscope and clean gloves. And we're going to make sure that we're doing this assessment under the infant warmer, since babies can lose a lot of body heat if they're exposed for a long period of time. So the initial assessment should be done under the radiant warmer. Before we even start to unwrap the baby, we can look at their sleep-wake cycle. We're going to observe whether the baby is in a deep sleep, light sleep, are they drowsy, are they quiet alert, are they active alert, or are they crying. And then we're going to unwrap the baby and look at their muscle tone. Their extremities should be moderately flexed, not too flaccid, not too rigid. We're going to look at the baby's head and assess the skin on their head for any bruises or cuts. We're going to look for irregular shaped marks on the skin by the eyes. And there's two different kinds we're looking for. One, it's called a stork bite or telangiectatic nevi. This is a pink mark that will blanch when you touch it, and these usually resolve on their own. And then the other one is called a port wine stain or a nevus flammeus. This is purple to red in color. These do not blanch and usually don't resolve on their own. Then we're going to look at the sutures on the baby's skull. We have the frontal, coronal, sagittal, and the lambdoidal. And we're going to check to see if they are split, approximate, or overlapping. And we're going to check the baby's fontanelles, the anterior and the posterior. You want to palpate these. They should be soft and flat. If they are depressed, that can indicate dehydration, or if they're bulging, that could indicate increased intracranial pressure, hemorrhage, or even infection. So then we're going to look for any swelling of the head. And there's two different types of swelling that we're looking for. One is called caput succedaneum. This is edema that crosses over the suture lines. This is accumulation of fluid between the periosteum and the scalp. The other one we're looking for is called a cephalohematoma. And if you palpate this, this is a slightly firm type of swelling that does not cross suture lines. And this is a collection of blood between the skull and periosteum. So after we're done with the head, we're going to move on to the eyes. And we're going to check the placement of the eyes. They should be symmetrical. The character of the eyes should be clear. We're going to check for subjunctival hemorrhage. This is common and appears as a red patch on the sclera. This is common, caused from ruptured blood vessels of the eyes during the birthing process. There should be no discharge from the eyes, but the eyes may be a little swollen from the birthing process. The crying should be tearless because infants haven't formed their lacrimal ducts yet. And we're going to look at how their eyes react to light. Just make sure that they're squinting when a bright light comes on. And we're also going to look at the eyes for something called nystagmus, which is the involuntary back and forth movement of the eyes. So after the eyes, we'll move on to the nose. The placement should be midline, and infants should be nose breathers, so we check the patency by closing their mouth by holding our thumb on their chin, and then closing one nostril, and then we look at their chest to make sure it's rising up and down, and we do this bilaterally. There shouldn't be any nasal flaring. This indicates respiratory distress. And we also assess for a cleft lip. So then we move on to the ears. The outer canthus of the eye should be lined up with the top of the pinna of the ear. Lower set ears can be an indication of genetic abnormalities. The cartilage should be firm and recoil immediately upon pushing it forward to the face. The more preterm an infant is, the less recoil is seen during the recoil test. And the baby should be responding to voices and sounds with either moral reflex or turning towards the sound. Then we move on to the mouth. You want to apply gloves for this part. So we're gonna stick our finger in the baby's mouth, check their tongue. It should be symmetrical and move freely and not protrude. The gums should be pink, and note presence or absence of teeth. They shouldn't have any teeth. The palate should be intact and present. You wanna feel the gums and palates to observe findings. And then there's 3 reflexes we check with the mouth. First, you wanna check the suck reflex. Just by putting your finger into the middle of their mouth, and the baby should start sucking on it. Then we assess the gag reflex by putting our finger a little deeper into the mouth and actually touching the back of the throat, and the baby should gag immediately. Then we assess the rooting reflex, which is by stroking the cheek, and the infant should turn their head in the direction that you're stroking their cheek. Also with the mouth, we want to check for circumoral cyanosis. This is blueness around the mouth. This is a sign of respiratory distress. So then you can remove your gloves, and we're going to move on to the chest. The chest should be shaped like a barrel, and you should see diaphragmatic respirations. The baby should not be experiencing any intercostal or substernal retractions. The clavicles should be intact, and we check this by palpating the clavicle while rotating their arm and feeling for any crepitus. Also, if you're moving their arm and the infant starts to cry, in a high-pitched cry, that could indicate pain, also a sign that their clavicle could be broken. And you do this bilaterally. The nipples should be symmetrical and well-formed with prominent breast buds. You want to auscultate the heart rate. For infants, we always check their heart rate apically, and a normal beat is between 100 and 160 beats per minute. And we do this at the 4th or 5th intercostal space at the left mid-clavicular line for the apex. Murmurs are abnormal and should be reported. So we're going to listen to the 5 different heart sounds, starting at the right 2nd intercostal space, or the aortic valve, the left 2nd intercostal space, the pulmonic valve, the left 4th intercostal space, the tricuspid valve, the left 5th intercostal space, the mitral valve, and then the left 6th intercostal space. And while we have our stethoscope here, we can listen to their respiratory sounds. These should be clear bilaterally. You want to know any grunting, nasal flaring, or intercostal or substernal retractions. These can all indicate respiratory distress. We want to auscultate the breath sounds in a pattern, starting with the right upper lobe, then the left upper, the right middle, the right lower than the left lower. And you want to know any crackles or wheezes, as these indicate fluid in the lungs, and absence of breath sounds can indicate atelectasis or a collapsed lung. So then we can move on to the arms, and this is a good time to check the baby's ID band, make sure this is the right baby. We want to check the brachial pulse bilaterally, which is right in their bicep. We want to check their grip reflex by placing a finger in the palm of their hand, and they should grasp onto it. And we want to know any acrocyanosis, which is when the head and the trunk of the infant are pink, but the hands and feet are still blue. This is common several hours after birth and usually resolves within a few hours. So then we want to check the Moro reflex, and there's two ways to do this. One, you can slam on the table and the baby's hand should curl like a C, and their extremities pull out. Or you can also gently lift the baby up with their head still touching and release, and this should also startle the infant and give the same reaction. So then we look at the abdomen. It should be round and non-distended. There should be no shiny or taut skin. No loops of bowel should be visible through the skin. And we want to auscultate the 4 quadrants of the abdomen, noting the bowel sounds. And we want to do this in a set pattern as well, starting with the right lower quadrant, the right upper quadrant, the left upper quadrant, and the left lower quadrant. Then we want to palpate the liver and look at their umbilical cord. It will have 1 artery, 2 arteries, and 1 vein. It should be clamped and odorless with no intestinal structures protruding, and this can actually be used as a pulse site for the first few minutes of life. Then we're going to look at the infant's genitalia. If it's a female, the labia majora should be larger than the labia minora, unless if it's a preterm infant. It may be slightly edematous due to the birthing process or hormone levels. Females also may have a pink, mucousy vaginal secretion due to maternal hormones. And we also want to check the patency of the anus. Their first stool, called meconium, should pass after 24 hours after birth. And then if we have a male infant, you want to assess to make sure that rugae is present on the scrotum, make sure that both testes have descended into the scrotum, and palpate these. They should feel like marbles. You want to make sure their urinary meatus is at the penile tip and note any deviation of that. Make sure there's no discharge or inflammation if they have been circumcised. And also with the males, you want to assess the anus and make sure that meconium has passed after 24 hours. So then we look at the infant's legs with their feet facing toward us. We check their thigh folds. They should be symmetrical. We want to check the femoral pulse bilaterally, but not at the same time to avoid eliciting a vagal response. We want to check the Babinski reflex, This is when you start at the heel and draw a C upward to the toes, and their toes should fan out. We do this bilaterally. And check the plantar grip by placing a finger under their toes, and they should grasp onto the finger. Do that bilaterally as well. The newborn's sole should be well lined on each side, and then note an identification band on the ankle if applicable. So the last part, we want to turn the baby over on their stomach to look at their back, and you can hold the baby like this with your hand under their chin, supporting them. So we want to look at the spine. It should be vertical and midline and easily flex. We're going to look for a sacral dimple and hair tuft. This is a sign of spina bifida and should be reported. Also on the back, we're going to look for something called Mongolian spots, which are normal. They look almost like a bruise, just a dark skin area over the sacral area. This is common in darker skin infants. It's nothing serious, but it should be noted in the baby's chart. So then when we're done, we can finish by swaddling the infant back up in their blanket and place them back in their crib or with their parents.